Alright, so in this session we are going to have a look at the cardiology changes on the CPGs. There's a couple of them, there isn't really tons of them. This is not going to be a complete another relook at the electrophysiology of the heart with regards to ECG interpretation. There is a cardiology day, CPD day. If anyone wants to join us, you're more than welcome. And we go in depth into STEMIs and looking at left bundle branch blocks and all that kind of stuff. So this is just going to be a quick run through the actual changes to the CPGs. Some of the stuff we're going to look at is the changes to the ACS, acute coronary syndrome, which required the practitioner to identify the potential for a posterior MI, which currently we do not do. Normally at the moment we're just looking at the anterior part of the heart. Knowledge objectives include identifying potential patients suffering an acute posterior MI, the ability to correctly and accurately place monitoring electrodes on the posterior of a patient, which we currently do not do. There is a practical session for this, and we're just going to touch on it, on the theory of it today. We're going to look and discuss CPG overview of tachyarrhythmias. So there's one there just with an overview of tachyarrhythmias, and then we're going to have a look at wide and narrow complex tachyarrhythmias as well. Okay. So a recap of the actual cardiac anatomy and physiology. This is stuff that I know you know, but just to kind of get us all on the same page, we're just going to have a little bit of a look at this, okay? So the heart itself, how does it work? What is it? It's a hollow muscular organ, again, sits in your chest. Its primary purpose is to beat, to eject blood around the body. The reason why we're looking to send blood around the body is to permit perfusion, to feed the cells fuel and oxygen and remove the waste products so they can survive. It has its own intrinsic vascular network to promote perfusion of the myocardium. So because it's an actual pump and it never stops moving, it has a high kinetic load, it has a huge need for its own blood itself for fuel and oxygen. And we'll have a quick look at that. The heart's intrinsic conduction system propagates and regulates impulse formation and conduction. Fancy words, it basically means that the heart's conduction system generates impulses and permits them to travel through the heart in a rhythmic manner to promote the actual heart's rhythmic motion, which allows blood to be ejected in a fashion that allows us to feed all the cells throughout the body. Impulses facilitate depolarization of coronary myocytes and physical contraction to pump blood, which is the end game of what this is all about. So, let's have a look. Short video.
The human heart has 4 chambers. The 2 upper chambers are the atria, and the 2 lower chambers are the ventricles. The interatrial septum separates the 2 atria, and the interventricular septum is the partition between the 2 ventricles. The right atrium and right ventricle are connected through a tricuspid valve. As the name suggests, it has 3 leaflets or cusps. On the other side, the left atrium and ventricle are connected through a bicuspid valve. The bicuspid valve is also called the mitral valve because of its resemblance to a bishop's 2-sided mitre or hat. The leaflets of these atrioventricular valves are connected to fibrous tissue called the chordae tendineae, which in turn are attached to papillary muscles. Contraction and relaxation of these muscles make the valves open and close. There are also valves at the opening of the pulmonary trunk and the aorta. These are called the pulmonary valve and the aortic valve, respectively. Because of their crescent moon shape, these 2 valves are also called semilunar valves. The characteristic double-up sound of the heartbeat is produced during the closing of the heart valves. The thickness of the walls of the 4 heart chambers varies with their functions. The walls of the atria are thinner than those of the ventricles, as the blood needs to be pumped into adjacent ventricles only. The left ventricle pumps blood a greater distance at higher pressure. Therefore, the wall of the left ventricle is thicker than that of the right ventricle. The sinoatrial node atrioventricular node, bundle of HIS and Purkinje fibers represent the specialized cardiac tissue. These fibers are autoexcitable as they have the potential to generate electrical activity without any external stimuli. This makes the heart beat continuously.
Armando Hasudugan, biology.
So, that information is information which you guys already know. Again, it's just a recap. So the heart is specialist cardiac tissue. It is cardiac tissue. It's not nervous tissue, but its sole purpose is to conduct impulses. The cardiac conduction system allows coordinated depolarization of cardiac cells. So the energy spreads throughout the myocardium in a regulated manner. Depolarization of cells is usually followed by physical movement. So as the energy runs over the tissue contracts. And we get this rhythmic contraction which facilitates the ejection of blood around the body itself. So coordinated movement facilitates effective and efficient ejection of blood through the heart's chambers and out of the aorta. And this allows systemic perfusion as cells are delivered fuel and oxygen while waste products are removed simultaneously throughout the body. So, the whole cardiac conduction system is really what allows the rhythmic beating of the heart to facilitate systemic perfusion.
As we unravel the mystery of the rhythmic beating of the heart, we come to realize that heart performs this function with flawless consistency. The heart is an organ that beats throughout the lifetime of a person. Are you aware that in an average lifespan of 70 years, it beats about 2.5 billion times? The heart beats rhythmically due to the electrical impulses which cause synchronized contraction of the heart muscles. These impulses cause the contractions of the atrium and the ventricles, which allow the heart to pump blood. But have you ever wondered what controls the heartbeat? Cardiac pacemaker. The heartbeat is generated and controlled by a pacemaker present in the heart. It also possesses specialized excitatory conducting system, which ensures the rhythmic beating of all the cardiac muscles. The walls of the atria form the atrial syncytium, and the two ventricular walls constitute the ventricular syncytium. The pacemaker is located in the wall of the right atrium. It is also known as a sinoatrial node or SA node. The SA node generates an impulse which spreads across the walls of the atria through the specialized conducting system, causing both atria to contract in unison. During atrial contraction, this electrical impulse reaches the atrioventricular node or AV node. Here the impulse is delayed for about 0.1 second, after which it moves along the bundle of His, bifurcates into bundle branches before spreading along the Purkinje fibers. The impulse reaches the lateral ventricular walls and causes its contraction. Thus, the impulse generated at the SA node causes atrial contraction and flow of blood into ventricles, and then the ventricles contract, pumping the blood out of the heart. It is the impulse generated by the SA node that causes the heart's chambers and valves to work in tandem. Thus, we conclude that it is the SA node as the cardiac pacemaker which sets the rhythmicity of the heartbeat. Summary. We can now observe the impulse conduction and heartbeat in synchronization with the blood flow. cardiac cycle begins with the SA node generating an impulse, which spreads to the two atrial walls and also reaches the AV node. The two atria, which form the atrial syncytium, contract. The AV node delays the transmission of the impulse by 0.1 second, which allows the atria to empty completely before the ventricles begin to contract. Then the impulse moves along the bundle of His and finally through the Purkinje fibers to spread all over the ventricular walls. Finally, the ventricular syncytium contracts, thus pumping the blood out through the aorta and the pulmonary artery. This is the end of one cardiac cycle.
Okay, there's some, excuse me, some nice visuals on that, and it's easy to kind of understand what it is the cardiac conduction system does. Cardiac arrhythmias are rhythms without rhythm. Ventricular arrhythmias, such as VF, or regular irregular VT. So rhythms originating in the atria, such as supraventricular tachycardias. These are the rhythms we're going to talk about. So they're either ventricular in origin or they're atrial in origin. They're either from upstairs in the heart or from downstairs in the heart. So the origin of the rhythm, and are the rhythm stable or is the patient stable or unstable? So where does the rhythm originate, the atria or the ventricles? How do we know the difference? Patients with tachyarrhythmias, is the rhythm regular or irregular? So is it a regular arrhythmia or is it an irregular? Is it a regular rhythm, a fast regular rhythm or fast irregular rhythm? Is the patient stable or unstable? And these are the questions that we normally ask. So where does it originate? Is it from the atria or from the ventricles? From the ventricles, it tends to be a little bit more unstable. So is it from the atria or the ventricles? Is it regular or irregular? And is the patient stable or unstable? These are the questions that we're looking to ask. Broad complex rhythms are ventricular in origin. So anything that's broad, this is from the ventricles. This is broad too. People think it's narrow. These are actually far greater than 3 small boxes or 0.12 of a second. So these are ventricular in origin. This one here, this VT, ventricular tachycardia. What's the rate? The rate on this, there's 2 big boxes, about 150. That's a ventricular tachycardia, or that's a VT, a broad complex VT. This one here, this is another VT. It's irregular. The shape changes on it, and this is torsade de pointe. So this is an irregular VT. Stable or unstable? So is the patient is symptomatic of hypoperfusion? Are they symptomatic? Have they a change in level of consciousness? Are they unconscious? Is their blood pressure depressed? If they've got depressed BP, then the heart might be doing 150 or 200, but it's not ejecting enough pressure from the pump itself, which means the brain and the vital organs are being hypoperfused. These people need to be seen immediately, and these people we will always ask for ALS. Narrow complex rhythms are atrial in origin. So these are quite narrow. Look, these are really narrow. Far less than 3 small boxes. If you were to look at these, this one here is about 1 small box, and this one here at the apex is less than 1 small box. So these ones here, so this is your typical kind of SVT, supraventricular tachycardia. This rhythm originates above the AV node, and again, this is all covered on our cardiac CPD day if you guys want to come and sit in on it. This one here is A flutter, typified by the sawtooth formation in between the QRSs. Normally sits at about 150 is kind of typical of that. SVT and A flutter. So regular complex rhythms, atrial in origin. So irregular narrow complex rhythms. So the other rhythms we seen were regular. These guys are all regular. Serious regularity to these. So these originate in the atria and they're regular. These ones here originate in the atria, but they're irregular. So the first one is probably the most common arrhythmia you'll see pre-hospital, which is atrial fibrillation. You can see from the R waves, they're not equidistant. They're all kind of different. It's a slow AFib. This one here is a fast AFib, and it's much more noticeable that we have bigger gaps and smaller gaps in between the R waves, and you have your typical fibrillatory waves here between the complexes. So again, this is your narrow complex, so it originates in the atria and it's irregular, as opposed to the last ones which were regular. Stable or unstable? So is the patient symptomatic of hypoperfusion? Do they have an altered level of consciousness? Have they got a low blood pressure? These things really, somebody who's normally GCS 15 chatting away to you. They have a sudden onset of a cardiac arrhythmia, be it broad or narrow, and their blood pressure is maybe 60 or 70 systolic. They have an altered level of consciousness or they're unconscious. These people are critically ill and they need to be dealt with straight away. So here's the overview that they've put into the CPGs. So it's just a tachyarrhythmia overview. Monitor ECG SpO2 and give some oxygen therapy if appropriate. Acquire a 12-lead ECG and request ALS. Absolutely. So we split it into two sides here, narrow QRS or a wide QRS. And we've looked at examples of both. So your narrow QRS is less than 3 small boxes or 0.12 of a second. It's either regular or irregular. If it's regular, the differentials include SVT or A-flutter. If it's irregular, it is most likely AFib or multifocal ATAC. So there's a couple of different differentials. The differentials are what they are. We kind of need to have an understanding certainly of what they're about, particularly the SVTs. If we pop over to this side, we're looking at wide complex QRSs, which means they're ventricular in origin. So differentials here, ventricular tachycardia, VT. SVT with aberrant conduction, so conduction that's going back from upstairs back into downstairs again, and it's like a washing machine spin cycle. It goes out of sync and the heart just beats really, really quickly. And because it's beating so fast, it's not generating any kind of output, any kind of pressure into the pipes. Irregular again, YQS go to tachyarrhythmia. So differentials here, polymorphic VT, which we've seen. Polymorphic VT is your multiple shaped ventricular tachycardia, which is your Torsad. Atrial fibrillation with aberrant conduction as well. And again, all of these particular rhythms, we have to run on the assumption of an upskill that you're up to date on and au fait with. If you want to come and do the day with us, you're more than welcome. ACS or acute coronary syndrome, which is an umbrella term for situations in which we have hypoperfusion of the cardiac myocytes themselves. Blood supply to the heart muscle is suddenly blocked as per the American Heart Association. The blockage can be from what? A blocked artery. It can be from numerous things. So includes hypoperfusion to the myocardium and promotes tissue ischemia and progressive cellular death if not reversed. If we have an ACS and we have a coronary artery which is blocked, which we have no blood flowing through, everything that coronary artery is now feeding is starting to die. If it starts to die, we're going to see changes on our ECG. New information on the ACS CPG, reference to a posterior MI and the necessity to perform a posterior ECG. So currently we do our typical 12-lead ECG. We put our 10 leads on, our 4 limb leads and our 6 chest leads. What we're looking at, using Einthoven's triangle, we're familiar with the views we're looking at. Predominantly we're looking at the front of the heart, the anterior portion of the heart. As per the last CPG upskilling, the 2017 CPGs, if we had an inferior MI, notably a STEMI on leads 2, 3 or AVF, we would automatically do a right-sided ECG. And the reason for that is the inferior portion of the heart itself is predominantly fed from branches of the right coronary artery. And again, what we're looking at here really is, we're talking about where is everything getting fed from. So if we're looking at the heart itself, so if we're looking at various arteries in the heart itself, and this is the heart muscle. If we have an infarct on this particular artery here, then the tissue that this artery supplies, which in this case is around here, this is the area where we would expect to see tissue death. If this tissue is starting to die because of ischemia, it will now no longer conduct electricity. We stick our monitoring electrode looking in this direction, and we see changes on our ECG. We see changes because the tissue that's being fed by this artery is now starting to die. And we start seeing stuff like the emergence of an ST segment elevation, MI. We predominantly place our 6 electrodes on the front of the heart. Leads 1 through 4 are looking really anteriorly at the front of the heart. 5 and 6 is looking laterally to the side. So if we have something going on the back of the heart, we're not going to see it. If we're looking at the likes of an ST elevation segment, what are we looking for? We're looking for something like this. QRS complex, and on the way down we have this hyperacute ST segment elevation. So we can see lots of these, and that's fine. And this is an indication that there's current injury to the heart muscle itself. We will always look for these. If we see ST segment elevation, we will look for the mirror image of that on another part of the heart that's somewhere on the other side. And what we look for is ST depression. So this is basically the upside down mirror image of. These are known as reciprocal changes, as you guys know from your original training. And if I'm seeing the likes of ST elevation, I automatically look in the other leads for reciprocal changes for ST depression. If, however, I just see ST depression on its own on the anterior leads, but I don't see elevation, then where's the injury? If I'm seeing depression on the front, maybe the injury's on the back, but we don't currently place electrodes on the back to look for STEMIs. So what this CPG is proposing is that if we see ST depression on the anterior leads, that, you know, if the patient is symptomatic mean they have the look, they're grey, they're vomiting, they're nauseous, they have central chest pain, you know, all of the things that we currently associate with somebody having an MI. If they're symptomatic and they have ST depression on the anterior leads, we would now propose that we put a number of electrodes from the front around to the back to see if there's ST segment elevation. So what we're doing is a posterior MI. And this is the new proposal on this particular CPG. Right. So, here's the ECG itself, acute coronary syndrome. It talks about here STEMI, inferior MI, and isolated anterior ST segment depression. We can have a look at it a little bit further in. So it's telling us here about the criteria for STEMI. So ST segment elevation in greater than 2 contiguous leads, contiguous being leads sitting beside each other. In other words, I have a window here and a window here and a window here. Anything that's beside each other is looking out at the same part of the heart itself. Having a look at one window here or one view here and one view way over there, we're looking at different areas, so there needs to be at least 2 contiguous views. So you're talking about elevation of greater than 2 contiguous leads, of greater than or equal to 2 millimeters in V2, V3, or greater than 1 millimeter in the other leads. Or a new presumed left bundle branch block with symptoms of acute MI. In other words, the patient is symptomatic, and you see the emergence of a left bundle branch block. Again, in red, the other information here is talking about inferior MI, like we've discussed already, the necessity for doing a right-sided ECG because of the potential for right-sided infarct, due to the fact that the underneath of the heart, the inferior of the heart, is primarily fed from branches of the right coronary artery. The last one here says isolated anterior ST depression should prompt a posterior ECG. So if we see ST depression on the anterior leads with no elevation anywhere else, we need to have a look around the back because that's probably where the MI is. And remember, we have plenty of blood vessels around the back of the heart and on the lateral walls of the heart. It's just we don't happen to look there at the moment. Predominantly up until 2017, we really only looked at the left ventricle. Now we will, at least with an inferior MI, have a look at the right side of the heart. The current thinking now, if we've isolated anterior ST depression, we will have a look at the posterior portion of the heart. And again, the ECG or the algorithm just runs itself. Everything in blue is relevant to paramedics, so you have your GTN, your aspirin 300 milligrams, etc. Clopidogrel 300 milligrams PO, greater than 75, or ticagrelor is in there too, which is on the orders of PPCI, on the orders of your cardiologist. And transport primarily to the PCI, and that's really the actual algorithm. The algorithm is quite good. The interesting thing on the algorithm is this new information here with regard to doing a posterior MI, and that's why we're having a chat. So causes of acute coronary syndrome. Causes include AMI, acute myocardial infarction. Angina, both stable and unstable, can produce an ACS if we get an acute narrowing of an existing chronic blockage. May manifest on the ECG as ST segment elevation, a STEMI. We may also see new onset left bundle branch block, but our patients will need to know their cardiac history. They need to be able to say definitively, I have had no issues with left bundle branch blocks. We don't know if it's new or old. Okay. STEMI and LBB, there's your typical STEMI there. And again, you know, it's a pretty barn door STEMI, that one there. That patient being symptomatic that's a definite barn door STEMI. This particular one at the bottom, we're showing left bundle branch morphology. V1, we have broad complex QRS. We have a deep S wave. And conversely, on the lateral leads here, V5, V6, we have this RSR complex, and again, a broad QRS. Typical morphology of left bundle branch block. Relationship between ST elevation and infarction. So to be electrically conductive, as I've mentioned, the muscle needs to be alive. You know, tissue that's died due to infarct will not conduct electricity, and this will manifest itself as changes on the ECG, predominantly with STEMI. The proximity or location of the electrically dead tissue is important. Anything that's in the region of a particular blood vessel, then that blood vessel is probably the culprit. In other words, tissue adjacent to the right coronary artery that's shown as STEMI in this particular area on the right side, we're probably looking at a right-sided infarct. Death of tissue is usually as a result of infarction or blockage of the coronary artery that feeds this area of the muscle. So maybe the thing to do would be to have a quick look, which you may or may not have done, at coronary arteries, the main coronary arteries and where they sit.
Armando Hasudungan, biology and medicine videos. Please make sure to subscribe, join the forum group for the latest videos. Please visit Facebook at Armando Hasudungan. In this video, we're going to look at the coronary artery and the cardiac veins. So the coronary blood supply is the circulation of blood in the blood vessels of the heart. You have coronary arteries and the veins. Let us look at the coronary arteries first. Coronary arteries supply blood to the heart muscles. So we'll first look at the anterior view of the heart and look at the coronary arteries from there. So here we have the aorta in red, rich in oxygenated blood. The two main coronary arteries are the right coronary artery and the left coronary artery. Concentrating on the right coronary artery, it will divide into the right posterior descending artery that goes around the back, and we have also the acute marginal artery, that the small heart that you can see in the front. And these arteries from the right coronary artery will supply the right atrium, the right ventricle, and the sinoatrial and atrioventricular nodes, which are the conduction systems of the heart. Unfortunately, I have not drawn these names here. Anyways, we also have the left coronary artery that will divide to the left anterior descending artery and the circumflex artery. These arteries will supply blood to the left atrium and the left ventricle. Now, if we look at the heart from the posterior view, so from the back, here we have the left side of the heart and here we have the right side of the heart. And just so we know where we are, this is the right atrium here, and this is the left atrium here. Now let's continue looking at the coronary arteries which came from the anterior view. This is part of the right coronary artery, the posterior descending artery that wraps around to the back here and supplies the right ventricle and the right atrium with blood. On the left side here is the circumflex artery, which I mentioned, that wraps around and supplies the left atrium with freshly oxygenated blood. Wherever there are arteries, there will always be veins. The veins will leave the cardiac muscle cells and will bring the deoxygenated blood back to the right atrium through the coronary sinus. So the veins that will bring the deoxygenated blood back to the right atrium. It will bring it through the coronary sinus. So all the deoxygenated blood from heart muscles will go back through the coronary sinus back to the right atrium. You have the small cardiac vein from the right side of the heart joining with the coronary sinus. And then the middle vein from the right ventricle here joining onto the coronary sinus. We also have the posterior vein from the left ventricle joining onto the coronary sinus, bringing back deoxygenated blood to the right atrium. Here we have the great cardiac vein, which we can see comes from the front of the heart here. This is the great cardiac vein. And just to remember, this is the small cardiac vein here. Also,
just having a really quick look at this. The amount of blood vessels here is enormous. And the only time or the only place we ever usually look is on the left ventricle, at the left anterior descending coronary artery. You can see the branches of the right coronary artery becoming the right posterior coronary descending, and then the branch of the circumflex artery coming around the back here. The back of the heart muscle itself is very vascular, and we never looked here for infarct. So seeing ST depression on the front of the heart, on the anterior of the heart, would automatically now in your head, looking at the amount of blood vessels here, you'd be thinking, my God, maybe the STEMI is from the back of the heart.
Well, that is very important. There is an anterior vein that does not join onto the coronary sinus, but drains blood directly to the right atrium. So this vein is very important to remember because the anterior vein does not join to the coronary sinus, but drains deoxygenated blood directly to the right atrium.
Again, have a quick look there. There's a nice view. Have a look at all of the vasculature here, both anteriorly and posteriorly. The only place we ever really looked traditionally was here. In the 2017 CPGs, we're looking, at branches of the right coronary artery because again, it comes in here and it feeds a lot of the inferior of the heart. Now we're proposing that any kind of, ST segment depression in this area here will be the mirror image of what's going on with elevation on the back. That's all. So I hope that helped. It certainly is a good visual. So coronary artery is looked at on the 12-lead ECG. So usual 12-lead ECG looks at the anterior arteries like I've just said. V1 to 4, V1, 2, 3 and 4 is looking at the electrical activity in the septal anterior anatomical areas of the heart muscle, which is all really left coronary artery kind of territory, I suppose. V5 and 6 looks at the electrical activity on the left lateral wall, which is a branch of the left circumflex artery, and this continues on around to the posterior part of the actual muscle itself. Areas not looked at on the ECG, we do not routinely look at the right side of the heart during normal 12-lead acquisition unless we suspect an inferior MI. We mentioned here the dominant arterial feed to the inferior portion of the heart comes from branches of the right coronary artery, which is the reason why now we do right-sided ECGs. And again, moving that on another step, we also do not routinely look at the posterior view of the heart. When ST elevation on an ECG, we look for reciprocal changes, we look for ST depression. So if we have ST depression on the anterior leads now, we're asking you to do a posterior MI. So to move three of the leads around the back and have a look at what's going on electrically there. And if we see ST segment elevation there, it's definitive that patient needs to go to PPCI. How do we do it? We simply take leads V4, 5 and 6 and move them to the posterior thorax. So V4, 5 and 6, we just pop them off and we'll move them around to the back to form V7, 8 and 9. So V4 goes to V7, V5 to V8 and V6 goes to V9. Left posterior axillary, tip of the left scapula, a left paraspinal region, and I have a couple of little drawings or diagrams to have a look at now. This is the practical portion of the skills station that you will do on your skills day here in the training centre. So arm and leg electrodes remained unchanged. V4 goes to 7, 5 goes to 8, 6 goes to 9. We have to handwrite posterior leads on the actual ECG itself, and I'll show you a picture of that now. Let's have a look. So V7, left posterior axillary line in the same horizontal plane as 4 to 6, which is the fifth intercostal space. V8, tip of the left mid scapula in the same horizontal plane again, the fifth intercostal space, and V9 is paraspinal just to the left of the spine, again fifth intercostal space. V6 is a good reference point for the horizontal placement of V7 to 9. So we have V6 here, that particular line is going to continue around the back, like so. So V7 is the left posterior axillary, V8 tip of the left scapula, and V9 is the left paraspinal region. And again, this is something that you're going to do practically in the training center. These particular diagrams, these three diagrams, and indeed the videos that are in this particular session are on your Moodle as separate files, which you can have a nosy at yourself. How do we mark it up? So we get somebody who's got ST depression here in V1, V2, V3. We move the leads from V4, 5 and 6 around to the back, and we X them out and they become V7, 8 and 9. So I know these are posterior leads. And amazingly, there's ST elevation on the leads on the posterior of this patient, which mirror the ST depression on the anterior. Okay. In conclusion, so tachycardic rhythms, there's a new overview on the CPGs which we've had a look at. Narrow and broad complex, narrow being atrial in origin, broad being ventricular. Then we look at, are they regular or irregular, and is the patient stable or unstable. Review the causes of acute coronary syndrome, and we acknowledge the relationship between areas blood vessels perfuse and changes electrically on ECGs. Recognition of the necessity to record a posterior ECG for ST depression in the absence of elevation and the rest of the strip. ST depression on the anterior leads, isolated ST depression on the anterior leads would lead us to suspect a posterior MI, and we would go ahead and place leads 7, 8 and 9 on the back from 4, 5 and 6. And again, practically you will do that here in the training centre. That's the end of this session. I hope it casts some light onto the changes that are in the CPGs, and if you guys feel that you need to come and do the CPD day on cardiology, please be my guest. It'll be extremely easy to understand language, quite practical and very visual. Thanks guys.